I'm Maya Maxim, one of the pediatric hospitalists at Kapiolani and one of the co-leaders of Pediatric ECHO. We're super happy today to be hosting Dr. Rodolfo Begue, our newest addition, but not even that recent anymore, to the infectious disease group here at Kapiolani. Always helpful to us inpatient when we have complicated infectious disease stuff. So we're hoping to make a topic that maybe has been very mysterious to everyone, a little bit more approachable with this topic. And then always remember that it's fine to ask questions at any point. You can drop comments in the chat, questions in the chat, and I will interrupt if it's like a clarification kind of question. Otherwise, if it's something that can wait until the end, or if you have a case that you wanted to talk about a particular patient, especially the testing for CMV in infancy can be very confusing. So, if you have any questions about that as well, please feel free to drop all that stuff in the chat.
Okay. Thank you. Thanks for the invitation. Thank you, Dr. Maxim, and thanks for all of you to spending a few minutes with me. I'll try to go over this topic of congenital CMV. And yeah, as implied, yeah, it is sort of complicated. And why? Why is it so complicated? Well, the answer is simple. We just don't have all the information that we would like to make the decisions. Interestingly enough, for the past 2-3 decades, we have learned a lot about the epidemiology of congenital CMV, and you will see that on almost any review that you can read. In the past decade or two has been some interesting progress in terms of treatment, but what we still don't have much information is about indications, exactly who would benefit from that treatment. So who needs to be evaluated, who needs to be treated, how to follow, and those kind of things. So the practical aspects of congenital CMV, I'm afraid, are not as clear as we all would like to think. And I'm going to try to go over those details with you in the next few minutes. And maybe, if not answering many questions, at least give you the tools that you will need to make the decisions on your patients. Have no disclosures. These are the objectives for today. Recognize how important congenital CMV is. Being able to say how to diagnose CMV, how to identify those who need treatment, and then especially the gaps in the knowledge and how you sort of individually can try to fill those gaps to make your own decisions. So let's start with the basics. Why do we worry about congenital CMV? Like many things in medicine, there's 2 reasons. One is the frequency, and 2 is how serious it is. So let's check out each one of them. How frequency is congenital CMV? Well, it's the most common congenital infection in the US. That's what you can read everywhere. Now, from being here in Hawaii for about 2 years, it's actually maybe second to syphilis, because I've seen way many more cases of syphilis than congenital CMV. Now, the caveat is that for congenital syphilis, we test everyone. While for congenital CMV, we don't test everyone. And that's one of the points that I'm going to try to make over and over again, that we are missing probably too many cases of congenital CMV. Worldwide, data is sketchy. It comes from small studies in very particular populations in few countries, but worldwide is estimated to be about 0.6%. In the US, it's a little less, maybe more closer to like 0.5%. In Hawaii, there is no data whatsoever. So we have no idea if we, like the rest of the US, are on the 0.5%, maybe we're more on the 0.6%, or maybe we are even higher. And maybe I will try to make a case that there is some reasons why we may actually be higher than that and more closer to 1% or even more than that. How do babies get CMV? Well, the answer is simple, right? From a mom while they are in utero, right? That's why it's a congenital infection. And there's 2 scenarios for the mom. The mom is pregnant, she had never had CMV, and then she catches CMV during pregnancy. That's what would be called primary infection, right? This happens mostly on young pregnant women who are around young children, whether due to family or work exposure. And the second possibility is the woman is pregnant and she already had CMV positivity from antibodies that she acquired way past then. And now she has either a reactivation of an old CMV disease or she catches a new CMV disease, right? Because CMV does not give you full immunity like chickenpox would or measles would or others would, right? For CMV, immunity is partial. There's too many types of CMV out there. And even though you have one, you may be infected with another one. This is what is called a non-primary infection. That is a term that I personally don't like for two reasons. One is you are not supposed to be named by what you are not. You're supposed to be named by what you are. So non-primary infection as opposed to primary infection is not a good name. Secondary infection probably makes more sense to me. And two is because I think the outcome from reactivation disease may be different than those that come from catching a new CMV disease, right? By definition, if you reactivate your old disease, you have antibodies, you pass antibodies to the baby may be exposed to a reactivation, but the baby already has antibodies and has some level of protection. Well, if this happens from catching a new infection, chances are your antibodies are not protected to the new infection, so the outcome may be different for the baby depending on each situation. So I think this is a bag that is including two potentially different scenarios with potentially different outcomes for the baby. But that's how you're going to read. Every review you read is going to use that. And why is that important to make that distinction? Is because the transmission to the baby varies depending if mom has a primary infection versus if she has a non-primary infection. If mom has a primary infection, meaning she was not immune to CMV and now is catching CMV for the first time in her life while she's pregnant, the chances of transmission to the baby are much higher, 30 to 40% in the first and second trimester, and 40 to 70% in the third trimester. So basically around 40 to 50% if you have a primary infection. And if it's a non-primary infection, the risk is 10 times lower, down to 3%. And the difference is not just that one transmits more than the others, but actually the primary infection leads to complications, to clinical symptoms more than the non-primary infection. So how many women out there who are having babies already have CMV and how many do not have CMV? And this is old data that come from N. Haynes back in the 90s. There's no more current data for this kind of seroprevalence study, but there's no reason to think it has changed. So I think we can still use this. And what basically shows you is that women who are having babies, if you are depending on your ethnic, racial background and social situation, it may vary, right? And basically in this only graph that we have, white women, where about 40–50% of them already had CMV, 40–50% have not, while in any other group, non-whites, it was more like 70%. So I assume here in Hawaii, our population, most women who come to have babies, about 70%, let's use that number, probably already have had CMV, and about 30% may have not had CMV. The 30% are the ones who may catch new infections and pass to the baby, and the babies have more symptoms. The 70% are less likely to pass to the babies, but those babies will present without any symptoms, which may make identifying them more difficult. And that's partly shown on this very old slide that again has all this data comes from the 70s, 80s, but is what we all use, that shows the rate if a woman has not had CMV infection and now she's pregnant, the chances of getting CMV infection, right? And it's much higher in those who are around children who are shedding CMV, 13 to 47%. Also very high at those among women who work daycare because they're around children, many of which may be shedding CMV, 8 to 20%. Pregnant women is lower, but it's still 2.5 to 6.8%, but it's still, percent, but it still is higher than blood donors, which is sort of like general population, which is about 2%. And interestingly enough, hospital employees is also about 2%. So we get in ID, especially doing infection control, we get this problem many times. Nurses who are pregnant and there's a patient with CMV in the floors and they don't want to, they're worried about taking care of the patient for many reasons and all that. They don't want to catch CMV and those kind of things, which is understandable, but they need to understand that they have the risk of catching CMV is more when they go home and they're around their own kids or family kids than when they're around children here at work, simply because at work you take a lot of precautions, you gown, you glove, and all those kind of things. Well, you don't do that when you're out there in the community. So these are the numbers that will help us understand what is the risk of a pregnant person to catching CMV if she has never had that before. And that's what I tried to show on this diagram here, which summarizes a lot of information from many studies over 2-3 decades on the epidemiology of CMV. Starting at the top, you have all pregnant women, and let's say again, 70% are CMV positive, as we saw in that graph before, and 30% are CMV negative. Of those that are CMV negative, about 2 to 5%, which is what I just showed in the slide before, probably will acquire a primary CMV infection, meaning that you go from antibody negative to antibody positive while you're pregnant. It's important to say that we don't monitor, we don't screen these ladies for CMV when they're pregnant, so we don't know how many actually convert, but the studies suggest that about 3%, 2 to 5% of them will convert to primary and catch primary CMV infection during their pregnancy. If that is the case, then about 40 or 50% of them will transmit that to the baby. So about 4, if you run the numbers, then about 4 out of 1,000 pregnancies that come down this way on the left, then will end up having cCMV. On the other hand is the group that are CMV positive, and which is 70% of them, and about 50% of them will reactivate their CMV during their pregnancy or will catch a new CMV, and then about 1%, 0.5 to 2% will transmit that to the baby. And again, if you run the numbers, then you end up with 7 per 1,000 pregnancy. If you add the two of them, it's about 11 per 1,000, or about 1% of pregnancies that will end up having a CMV infection. But also important to make a point is that most of those who end up having congenital CMV infection come from CMV positive moms, not from CMV negative moms. Even though CMV negative moms transmit more frequently than CMV positive moms, because CMV positives are more frequent, they end up producing more infected babies than the CMV negative moms. And you remember, because those come from moms who are CMV positive, they're usually asymptomatic. So if you are checking for CMV only babies who have symptoms of CMV, classical symptoms, then you are missing too many of them. If these numbers are true and you end up with about 1% of babies infected, then in Hawaii, you would expect to see about 160 babies being born with congenital CMV every year. At Kapiolani, about 60 cases a year, and the NICU should have at least 10 babies identified with CMV infection every year. Is that what we're seeing? Not at all. Not at all. We're not seeing this kind of numbers, which means that we might be missing a lot of babies with congenital CMV. Why? Because they're born asymptomatic. If we're only testing babies who have symptoms of congenital CMV, we're just missing too many of them. All right, that's about frequency and the difficulty of detecting asymptomatic babies. Now let's move to severity of the illness, which is the other side of the coin, why we worry about congenital CMV, right? And this is images from the Red Book online, and which depict the usual, the traditional, the classical congenitally infected baby. And on the left, you have the list of all the symptoms that they can present with: rash, jaundice, microcephaly, low birth weight, hepatosplenomegaly, seizures, retinitis, petechia, hepatitis, pneumonitis, intracerebral calcification. So most people will identify any baby who's born with this constellation of symptoms, will identify as possible CMV, would test and would, identify these cases. But unfortunately, these are the minority. 90% of those who are born with congenital CMV infection are asymptomatic. Only 10% will have any or some part of this constellation of symptoms. So again, if we're testing only based on symptoms, we're missing 90% of the problem. Still, even those who are born with minimal symptoms or with no symptoms can go on with having the problems, the sequela of CMV. Of course, those who are more symptomatic would have sequela more often, but even those who are asymptomatic can go on to have sequela with important significance. And the most common one is hearing loss, right? Developmental and motor delay also happens less frequently, fortunately. Vision loss, microcephaly, seizures, and death are way, way less common, but still they can happen. And that is partly shown on this slide here, which is, this is an old slide. I couldn't find the actual source, but it's somewhere in the New England Journal of Medicine from the 60s, 70s, 80s. And basically what it shows is the rate at which symptoms appear in babies who have CMV infection. The lower line is the primary infection. So when a mom is CMV negative and then she acquires CMV during pregnancy, and the baby is likely to be born with symptoms, as you can see, soon after birth, many of them will have symptoms, 10, 15, 20%. But even after that, 2, 3, 4 years, they still continue to develop complications from CMV. And at the end, it's more like 30 to 40% that will end up having some sort of symptoms, as opposed to those who are born to man with non-primary, or here called recurrent infection, most of which are born asymptomatic, and then little by little, a few weeks later, probably more like 6 to 8 weeks later, or even more than that, they start to develop symptoms little by little, and at the end, about 20%, 15-20% of them will end up having symptoms. So number one is many symptoms are not present at the beginning, and two is even if present, they will continue to progress, not just over 3 months, 6 months, not even a year. Years later, more and more problems can be surfacing on these children. So there's a problem with severity at birth, which is morally for those who are born from primary infection, and a problem of a sequela later on, which is a problem of those with primary infection as well as those with non-primary infection. And the most important and problematic one is hearing loss. And I want to say a couple of words about that, because I actually was illustrated about this by Dr. Lynn Iwamoto, who is very interested in congenital CMV. Congenital CMV happens to be the leading non-genetic cause of hearing loss, right? Accounts for about 20 or 30% of hearing loss at birth. The others may be genetic or other reasons. Occurs in 50% of all of babies who are with symptoms of congenital CMV, which again is only 10% of the patients. But also occurs in 15% of those who are born asymptomatic, which is the other 90%. 40% of these cases of hearing loss will not be evident at birth. They will present later on. So if you are testing by symptoms, you're missing too many. If you're testing by hearing loss, still you're missing 50% of babies born with congenital CMV, and still they will go on to have problems in the future. And even more than that, 50% of children who have some sort of hearing loss due to CMV, the loss will continue to progress. So whatever the level you find at the beginning, it's going to get worse. Chances are it's going to get worse. If you're lucky, it may stay at the same level, but chances are it will continue to get worse. And there's not too much you can do about that. So this is literally a silent epidemic that we have to somehow approach. The only way to approach is by knowing better who's infected and trying to do something about them. But again, we need to change the way we're dealing with things. And this is a diagram.
Can I interrupt with a quick question from one of our participants?
Yes.
Renata is wondering if the hearing loss is usually equal bilaterally, or is there any pattern that tends to be characteristic of CMV-related hearing loss?
No, that's a very good question. Not in particular. It usually starts unilateral, then it becomes bilateral. It's usually asymmetrical. One ear is worse than the other. So yeah, many children may have severe problems with one ear while the other may be only mildly affected, or may have both severely affected. But there's no specific pattern that would differentiate hearing loss from CMV from other causes of hearing loss, as far as I know.
Thank you.
So this diagram, similar to the previous one, is trying to go down the route of, okay, hearing loss in babies infected with CMV. It starts with all live births, goes down to those who have congenital CMV, which are 1% of the population. Let's take that number as an easy one to work with. Again, on the right, 90% will be asymptomatic. On the left, 10% will be symptomatic. Of those who are symptomatic, 10% will actually die during the acute phase of CMV. And of those who survive, 50% or ballpark will go to develop hearing loss. So if you run the numbers, about 0.45 per 1,000 live births will develop hearing loss on this arm of CMV. And on the asymptomatic arm, 90% are asymptomatic, 15% will end up developing some problem with hearing, which leads you to 1.3 per 1,000 live births. So basically, it's about 1.8, 1.9, close to 2 per 1,000 live births that will end up with hearing issues, not immediately, but at some point in the future due to CMV. And once again, you can see that those who come from asymptomatic are more frequently those who come from symptomatic. So once again, if we are only checking CMV in those who have symptoms of CMV, whatever the symptoms are, as we discussed before, then we're missing 2/3 of the problems at least. And this is a very interesting data kept by CDC, and the last numbers we have come from 2019 about hearing loss in the US and in Hawaii. In the US, the rate of hearing loss in children is 1.7 per 1,000 population, while in Hawaii is twice as high as 3.9 per 1,000. And actually, Hawaii happens to be the #1 state with hearing loss. So there's a lot of hearing loss here. There's no reason to think, as far as I know, for a genetic or environmental reason to explain that. So a good part of that excess in hearing loss may be due to CMV, congenital CMV cases, which are missed because, again, we're only checking those who are symptomatic or those who fail hearing tests. And again, that has a very low sensitivity to detect the vast majority of patients. So far, summary is most cases of congenital CMV are asymptomatic. Of all the congenital CMV complications, hearing loss is the most common and most enduring. And the most cases of CMV, hearing loss, will present in asymptomatic babies. So let's move now to the practical aspects of how to identify these babies and how to treat them. Testing for CMV, first is what you don't want to do. You don't want to send for CMV culture or shell bio culture. Those are actually pretty good tests, but they're very laborious, and most labs will not do that and probably will take quite some time to get the results back. So probably that's not what you want. CMV serologies you don't want to do because basically you're testing mom's CMV serology. IgMs for babies may be suggestive of infection in the baby, but it's very inspecific. The sensitivity and specificity is low, and it may give you too many false leads that you don't want to follow. The test that you do want to do, if you're worried about congenital CMV, the first one, the preferred one is saliva PCR for CMV. It's very easy to obtain, takes only 20, 30 seconds to get a saliva, a swab, buccal swab, and then that is very highly sensitive, highly specific for CMV infection. Urine CMV happens to be, to some people, the gold standard, but it's more difficult to obtain. That's why saliva is the preferred. Some people, if they get a positive saliva, because it may be contaminated with breast milk, and may give you a false positive, they want to follow with a urine CMV. But here we do just a good saliva PCR, and if it's positive, it's positive. If it's negative, it's negative. Blood spots can be used to detect CMV DNA, and that's not a bad test. It's very specific. If positive, it is positive. The problem is that it's not too sensitive, only about, because it depends on the baby having viremia. And many of these babies, especially if they were infected early in pregnancy, by the time they're born, the viremia has cleared. They still shedding CMV in the saliva and the urine, but they're not having it in the blood, at least that can be quantitated. So the blood spots for CMV DNA, if they're positive, they're useful, but if they're negative, they do not exclude CMV infection, and they need to be followed by a saliva PCR or a urine PCR. One problem, and that's just the big thing, is that the test must be done within 3 weeks of birth. I'm afraid the Red Book and every other publication, if it's more than 3 weeks, you cannot tell for sure if this was congenital CMV or if this was early acquired CMV. And the reason is because it takes about 3 weeks from the moment of infection to the CMV to appear in the baby's system. So you would have to suspect CMV in the first 3 weeks of birth and do the test if you really want to make sure you diagnose congenital CMV. Anything after that may still be congenital CMV because they shed it for months, if not years, but also may be horizontally acquired CMV infection. And why you want to bother to test these kids and identify them? Well, one is because you can provide early intervention. If they have hearing problems, you can start acting on them, or neurodevelopmental problems, you can provide early intervention. And because actually there is treatment that you can offer to them. And the basis for the treatment, they come basically from one group, and I have nothing against them. I know them, and they're very good people, and they know what they're doing. But obviously, when it's just one group always saying the same, everything sounds like the same, and there's no dissenting voice. So you want to be careful that, well, what they say is very good, but maybe some other people have also very good ideas, right? And this is the group at Alabama. It was first run by Dr. Whitley and by Dr. Kimberly. And they've been working on CMV, and they have produced a lot of very good data in terms of treatment, partly epidemiology, but mostly treatment. And the main two ones are the ones listed here. The first one that appeared in 2003 compared the use of ganciclovir, which is IV, for 6 weeks versus placebo. And they found that when babies with congenital CMV got treated with ganciclovir, 50% versus 26% at 12 months were free of complications. So basically, those who got treated had twice as much a good outcome as those who never got treated. It was very restricted in terms of the kind of patient that they used, so much that they had to use 18 sites, took them 10 years, and all they collect was 42 children. So it was a very hard to do study. Because of all this, it probably will never be replicated. It just takes too much time, too much money to get one of these studies. But then they follow with a study in 2015 in which they moved from ganciclovir, which instead of putting a central line for 6 weeks and giving IV for 6 weeks, and there's a lot of toxicity, they moved to using PO valganciclovir, which is the oral form of ganciclovir. And instead of using for 6 weeks, they moved to use it for 6 months. So they compare valganciclovir for 6 months versus valganciclovir for 6 weeks. I should say that there's in the interim, there was another study that showed that the dose they use for oral valganciclovir is as good as the dose they use for IV ganciclovir. So we think these regimens are comparable, even though they were never compared head to head, they probably should provide the same results. And in this second study, which included 40 sites, and for 3 years, and they only could enroll 86 children. They found that at 24 months, 2 years after, those who got treated, their risk of having good hearing, so the rate of good hearing was 73% versus 57% those who received 6 months versus 6 weeks of valganciclovir, which is not too different than the 50% that they found in the previous study, by the way. So extending the treatment, so switching from ganciclovir to valganciclovir didn't lose any power, and extending the treatment to 6 months as opposed to 6 weeks gave you a better outcome. And not only on hearing, but also neurodevelopmental, as checked by the Bailey scores. And there was 2 scores that were significant. The others were not significant, but they all showed a positive trend. So in general, there was an improvement in the hearing and in neurodevelopment on these kids when they got 6 months of valganciclovir. So at this moment, the preferred treatment for these babies, if they're able to take PO, which most of them should, is valganciclovir 16 milligrams per kilo per dose twice a day, follow and give it for 6 months, right? The alternative, if those who cannot take PO, let's say they have necrotizing enterocolitis or some other severe problem that does not let them take PO, then you may have to start with ganciclovir for 1 or 2 weeks. And as soon as they can move to PO, then go to valganciclovir again to complete the 6 months of treatment. Any problems with the treatment? Yeah, there's always some issues, right? In the studies, they found that the main side effect of valganciclovir was neutropenia that was seen in 20% of children. So 80% tolerated without a problem, 20% had a problem. I have used this many times, many patients. I had only had problems with 2 patients, both of which were very preemie babies who just didn't tolerate the medicine. But other than that, the vast majority of patients tolerate this treatment without any issue. Still, because they could develop issues, it's recommended that they should be seen and have a CBC, basically looking for neutropenia at baseline, then 2 weeks, 4 weeks, and then monthly until you complete the 6 months of therapy. I should say that the Red Book, the last version, actually says to do CBC weekly for 6 weeks, and then at 8 weeks, and then monthly. So it's a little more CBCs than I normally do. I think they say that based on that. I would agree on that if you're using ganciclovir, which has more side effects, more chances of giving neutropenia. But probably for valganciclovir, I don't think you need to be that aggressive. But just so you know that some people would do it more frequently than what I'm telling you, 2 weeks, 4 weeks, and then monthly until 6 months. And then you check for neutropenia. And the number I've used is if the ANC is less than 750, then I stop the valganciclovir, check weekly, and usually in a week or 2, the ANC should come back over 1,000, and then I restart the valganciclovir, right? And then I go back to rechecking the CBC, and as long as they tolerate, I continue. If they don't tolerate, I may have to do that again. If I have to do that stopping thing because of the ANC 2 or 3 times, then I stop the whole thing altogether, and then they just move on. The Red Book for neutropenia uses ANC less than 500. I think that's a little too low. I don't want it to get that low. I think that may bring other issues. And to restart when ANC is more than 750, or give GCSF 1 to 3 days. I never had to use GCSF. I just do this stopping and restarting. And again, except for one case, I never had to completely stop the treatment with valganciclovir. And because of that, you must see the baby every month to make sure there's compliance, they're taking the medicine, examine them to make sure whatever symptoms they had is gone, or they're not developing new symptoms, problems with CMV, checking the labs, the CBC, and readjust the dose, right? As the baby gain weight, then because it's weight-based, the dose, then you have to readjust the dose. So it's a little problematic, or I guess a little work that you have to do, extra work on these kids, seeing them monthly and doing CBC and seeing the family and whatever. But once you explain the family, the potential benefit on the baby hearing better and being more normal baby, most families are more than willing to do that. And you can always introduce that into your regular checkups with the baby. So I don't see it as a major intervention. And then you obviously have to check hearing test for all children with cCMV. Basically, this is a list of all the times when you want to do that according to the AAP Bright Futures, which is basically every time you see the child, you want to check to make sure the baby is hearing appropriately. So as good as that is, the problem is that the indications are very restrictive. The Red Book and every other publication, again, and I insist, all those come from the same group. They're very good people. They know what they're doing, but obviously they have only one point of view. But their indications for who should benefit, who could benefit and should be considered for treatment with valganciclovir is very restrictive. Has to be more than 32 weeks gestational age, so all the preemies basically are out. Has to have moderate to severe symptomatic congenital CMV, which means that those who have only hearing loss don't count. And I mean, those are the vast majority. And has to be diagnosed in the first 3 weeks of life, which means that you have to basically test everyone regardless, otherwise you're going to miss too many. And the treatment is supposed to be started in the first 4 weeks of life. And this is because they made this rule so restrictive. That's why, going back to the studies, they had so much difficulty enrolling patients, because most patients will fall off those rules. Again, these are rules, these are recommendations, these are not mandates in any way. As long as you understand why they're doing that and you evaluate the case in front of you, and you think that still you can include that patient, I would say feel free to do that. This is the list of situations that they consider moderate to severe symptomatic congenital CMV. So these are the patients that would qualify for getting treated for with valganciclovir, provided they're more than 32 weeks, they're diagnosed in the first 3 weeks, and they can get started on treatment in the first 4 weeks, right? And basically is a couple, 2 or more manifestations of CMV infection. Let's say thrombocytopenia and hepatitis, or hearing loss and a rash or something like that, right? Those probably would qualify to get treated if they're detected early. And this is the list of those who do not qualify, which is the vast majority. Asymptomatic babies or babies who have only hearing loss do not qualify, even though, again, 90% will be like that. Or those who have just transient, let's say, elevation in the transaminases, and then the next blood test is normal, they would not qualify. For thrombocytopenia that resolves quickly, they would not qualify, even though many people would feel like it warrants to give them the chance. So the bottom line is no one likes that, including myself. What about preemie babies? They're the ones who get the most damage from CMV, congenital CMV, and they're not included. What about those who are diagnosed after 3 weeks? Just because you miss them by a few days, then they don't qualify. You cannot be sure they're congenital, but you have a hint that they're probably. What about those who don't have any symptoms, but they're positive, or have only hearing loss, but they're positive? What about before hearing loss progresses? If they have a little problem, that's when I want to treat them. I don't want to wait for them to develop profound hearing loss and then decide what to treat, because the medication, even though some may improve, most of them do not improve. The most you achieve is keeping them at their level. A few will. So the idea is not to let them progress, not so much to revert the damage that has already happened. And more important is, what about longer course of treatment? Why stop at 6 months when these kids can have hearing problems at 1, 2, 3, 4 years after the infection? Why shouldn't they be on a more prolonged course of valganciclovir? And well, the reason is the study was not done that way. It's as simple as that. But maybe that should be studied. So the bottom line is that probably we should everyone be screened and all positives be treated. That's not what we're doing now. We're not screening everyone and we're not treating everyone. And that's where the confusion comes, getting back to the title of the presentation. Now, there is hope. There's a bunch of studies going on in what is called clinicaltrials.gov that have to do with treatment for congenital CMV. The first two ones are highlighted. One is by the group in Alabama, by the way. The other one is by a consortium of other groups. But they're trying to look at answer some of this question that I just told you about. Should we expand the indications for the treatment of congenital CMV? The others have already been closed, and we are mostly European. They have been closed, and we're waiting to see what their results are. But I hope that in the next 5-10 years, we will have more information and we will have more indications for treatment of babies with congenital CMV. And getting towards the end, I want to show you discuss with you a brief case that we just recently had to show you some of the problems we have when we deal with these cases. This was a baby who was born full term, normal spontaneous vaginal delivery. He had some jaundice when he was born. So they checked the bilirubin, which was high, 12.7, with direct bilirubin low. They thought this was more physiologic. And then the baby was discharged at 2 days just to follow with the pediatrician. At 8 weeks of life, was seen with fever, 100.8. And then his white count was elevated, 33,000, and the platelets were a little low. So he was worked up for rule-out sepsis, was admitted, started on ampicillin and ceftaz. During the workup, they found that the ALT, there was some transaminitis, the ALT 648 and the AST 1400, and the bilirubin was much higher, now 32.1, and the direct bilirubin was like, 24.8. And they called GI, they didn't call ID. That was supposed to be I don't know, when you're mad at someone's face. They did the right thing. They added acyclovir. It's not a bad idea when you work in someone with rule-out sepsis who has this many organs involved to add acyclovir while you're working up. They did a hepatitis panel, A, B, C, and all that, which was negative. It's unusual for a baby this age to have acute hepatitis anyway. They even did a cholangiogram looking for biliary atresia, which was normal. And they did a liver biopsy. And the liver biopsy showed liver inflammation and giant cells, which are suggested, one is of an infectious process and two, a viral infectious process. And giant cells gets a CMV high on your list. So they proceeded to do CMV workup, and the PCR in saliva was positive, in urine was positive, blood was positive. They even sent a carriers that was positive. You really don't need all that, by the way. I mean, just one is good enough. The pathology, they stained the liver for a CMV, and it was negative. Probably the infection had already passed the liver, even though it had caused a lot of damage. And then they call ID. And they call ID, then ID recommended giving valganciclovir for 6 months. Start valganciclovir and give it for 6 months. The people in the NICU were worried, and they decided to start IV ganciclovir first. They gave it for a week, and then they moved to PO valganciclovir. And then you can see the discharge liver test, and 2 months later liver test, which are slightly better, but not too much better, slowly improving, right? So there's a number of things to learn here. One is, yeah, the baby had jaundice at birth, at least visually, and enough to be tested, and they didn't do a CMV at that moment. They waited until 8 weeks when he was very sick, and actually they moved more to some sort of liver problem, not so much infectious problem. And when it started to point to infection, that's when they moved to doing the infectious part. So they missed the opportunity to diagnose congenital CMV. And when they tested too much. Probably the saliva would have been good enough. If you have pathology, histology, then you can always do the CMV staining. That was a good idea, but the diagnosis was already clear. And then again, he was started on ganciclovir out of fear more than anything, when valganciclovir probably would have done. And then you can see probably the whole picture was due to CMV infection. And as you can see, even though the liver inflammation will get better, it will take long time to go away. Chances are, even at 6, 9, 12 months of age, this baby still has some liver inflammation, but it all should progressively get better. So this was not, they could not tell if it was congenital, but the thinking was that, well, the symptoms that he had before, probably it was congenital infection, not an acquired infection. Plus the severity of the illness is not usual for acquired, post-neonatal acquired infection, more congenital infection. So based on all that is that we decided, well, even though there's no proof because it was not tested before 3 weeks of age, still most likely this is congenital. Still this baby may benefit from the treatment. It's true, we're going to be studying more than 4 weeks, so it doesn't follow the guidelines if you want to, but still it's someone that there's a good chance may benefit from getting the treatment. And he tolerated the treatment well, completed the 6 months, and that's as much as we can tell. We don't still have the hearing test, by the way, he passed hearing test at birth. So that was a positive sign. But the point is that, yeah, we missed too many cases and we catch them only 1, 2, 3, 4 months later when they come with the complications. And at that point, going back and trying to redo what was not done is a little trickier than trying to do it at the beginning. So this is my summary, which is a little long summary, but will help you to pass the test. So pay attention. The epidemiology and frequency of congenital CMV in Hawaii is largely unknown. Dr. Lynn Iwamoto is spearheading a study in the NICU to try to clarify the frequency, the severity, and the consequences of congenital CMV here. And hopefully with that data, we'll be able to move on to do an interventional study and see if early detection and early treatment would improve the outcome of this baby. But that may take another 2-3 years to be completed. Most cases of congenital CMV are asymptomatic and are largely missed. While asymptomatic at birth, still many will progress to long-term complications. So we're doing a disfavor to them by not detecting them in time. Treatment with valganciclovir for 6 months is good, improves hearing and neurodevelopmental outcome, and that's the main reason why we want to pursue all this. But how to best identify these infected babies and those who will benefit the most is still being elucidated. Should we do universal testing? Should we do a special symptoms? When is the best time? What is the best method? These things that we still need to clarify here so we can have a better program. At this moment, the benefit of valganciclovir treatment is proven for those diagnosed in the first 3 weeks of life, those who are born more than 32 weeks, who have moderate or severe symptoms, and who can be started on treatment before 4 weeks of age. Isolated hearing loss is not an indication for treatment as of now. We think this will change. I hope it will change. There's a good theoretical and practical reason why it would be better to identify and treat all those children, but we still don't have the information, and we don't have it because the studies have not included them. It's not like we know they don't get any benefit or that they get any harm from getting the medicine. It's just that they have never been included in these studies, and we need to get information on that. And the most common side effect of valganciclovir during your treatment is neutropenia that sometimes may require discontinuation, and that's why you need to follow them monthly and do serial CBCs and do serial checkups to make sure if they develop neutropenia, you catch it in time and you stop the medication. And just I think this is my last slide, a word about why we don't have universal testing. Again, as you may have sort of noticed during the presentation, that's where I'm trying to go to. It's a multifactorial problem. We just don't have the data. That's the bottom line. And our intention is to try to produce that data and then have an intelligent conversation with the pediatric community to better decide how we're going to identify these children and how we're going to treat them. And this is some of the references that I choose today. And I finished now, and we have a few minutes for questions if there is any. Thank you.
There are lots of questions. The chat has been very active, but maybe we'll give everyone just a quick moment to do the poll, about a minute, and then we can move on to questions if that's okay with everyone. And Dr. Begue, if you're able to see the chat, feel free to scroll through. Otherwise, I'm happy to read the questions to you so that you can, focus on other things.
Sure, let me try to do that.
Okay, I can read. Dr. Perlis pointed out that there's a typo in question number 2, but I think it's okay.
There's always a critic.
On the other hand, it narrows down your choices.
But I think it doesn't matter. Sorry.
All right, folks. Well, you can keep taking a look at the poll if you want to, and anyone who's still answering questions, please go ahead. But there were so many questions that I wanted to try to get to a few of them. Raylan Minor apologized for having to leave, but asked, I thought, a very good question, which is, what about infectious precautions such as daycare or other, contacts for a child with congenital CMV who is asymptomatic? And the specific example was a parent had reported that PCP advised no pregnant women to be around a child, and staff are cautious of this unknown, especially in which you can be asymptomatic or reactivate. Dr. Begue, what are your thoughts on that question?
Yeah, that's a very good one and very frequent one. The answer is standard precautions are good enough. In the hospital, standard precautions are good enough. I understand that in other settings like daycare and others, those may be a little trickier, but washing hands is usually good enough. The secretions, the shedding of the virus is coming through the oral secretions or through urine on these children. So every time they're wipe their noses or change their diaper or whatever, they should be washing their hands. That should be
when
enough.
children are crying, and there's which happens a lot in daycare, is it okay for a pregnant woman to pick the child up and comfort them, or should that kind of thing be done by somebody else, if possible?
Well, yeah, that's a good one. I guess, well, technically there's two issues there, right? I mean, does that woman know that she's negative or is she positive, right? And chances are she's positive, right? Yeah. She's not negative. And but if she knows she's negative, let's say for whatever reason she has some risky pregnancy and she's been evaluated thoroughly and she knows she's negative, then probably she should try to avoid that situation. If she has to, then the best thing is to wear a mask, comfort the baby, and then wash your hands well.
Okay, thank you. The next question is about the specific types of neurodevelopmental problems that are reported in the longer term for kids with congenital CMV, and specifically whether they are known to include autistic or ADHD type symptoms.
Yeah, that's also a good question, but no, they're not part of that. They have mostly motor delays. But it's not, they don't show symptoms of autism or ADHD, no.
Okay. Another question was whether congenital CMV was known to be the cause of preterm births. And a second one is if you test for CMV in all babies who fail their initial hearing test in the nursery. Those are two separate ones. I was trying to hurry. So the first question is, does CMV cause preterm birth?
Yeah, the answer is maybe. I guess that's the best way. Congenital CMV is more common so it's more likely to transmit moms who are infected, are more likely to transmit to preterm products than to term products. And it's not clear if it's a transmission, the baby already getting infected when it starts delivery, or if it's the fact that you're delivering a more vulnerable baby, right? So it's not clear which one. I tend to believe that probably is the infection that starts the process and not the other way around. But that's my impression.
Okay. I think the answer to this is no, based on your presentation, but if you fail the hearing test in the nursery, do you automatically get tested for CMV if you're otherwise asymptomatic?
Yeah, no, it's not happening. It probably should be included in some way. You get retested, so that's usually it's not in the nursery, right? Most children are tested when they're ready to be discharged. And if they're failed, then they go to their pediatrician to get retested. If they're high risk and they're followed by the neonatal group here, they will retest. And if the retest is, again, they fail the test, then they will be probably tested for, I hope they're tested for CMV. That is not a rule, I understand, but it's something that most of them would do.
And would that fit within the 3-week window in general, given that, you know, lots of families don't necessarily make it back that quickly or might miss an appointment before getting rescreened?
Yeah, again, I understand. Yeah, that is part of the problem, right? Why saying 3 weeks, you have to test them within 3 weeks. The only way to get around that is doing universal testing and either retesting or going straight to testing them for CMV if they failed the first test, right? And I'm more, those who are in the NICU, somehow we have some level of control over them, even though, again, there's no universal rule about how to do that. Those who are in the regular nursery are the ones that probably will not get tested. The baby example I show you, he was in the regular nursery and he was not tested, you know, when he was born. So yeah, I understand. Yeah, the 3 weeks rule is a little tough considering that it just doesn't give you much time to make all these decisions, especially on babies who are not grossly symptomatic.
A follow-up to that, you did mention blood as an option. Has there been discussion anywhere that you know of adding CMV to the newborn screen? I mean, it's certainly more common than maple syrup urine disease.
Yeah. That's a good point, and it's been discussed. And there's no universal testing anywhere in the U.S. at this moment. There's a state, I think it's Minnesota, who just passed a law to look into the issue, and they're sort of probably going to be doing blood spots as a way of screening. But again, that misses too many. So most people in the field don't think that is the best way to do. If we ever do universal testing, that would not be the most productive one.
Okay. We are at one couple of minutes after 2. There are still a few more questions. I think maybe the one that we'll choose to close with, and everyone who's busy, feel free to leave. We appreciate you being here, but we know that folks have patients waiting and everything. What about the likelihood of other co-infections at the same time? If someone is symptomatic with CMV, do you automatically do a torch screen or think about other congenital infections?
No, I personally, that's more a clinical question. I don't think so. If the clinical picture fits CMV and is positive for CMV, yeah, that's probably, that would be your answer there. Other important torch infections like syphilis rubella are already tested for, so you would have an answer to them. But I don't think that because you have CMV, now you have to evaluate for toxo or some other HSV or some other congenital infection, as long as it explains your clinical picture.
Thank you so much. This was, I think, an incredibly enlightening and clear presentation on what's otherwise a very muddy topic. So for anyone who might want a quick reference guide, I grabbed a screenshot of the what to do for testing. I'm going to share that with Summer. So if anybody wants that, you can just go ahead and let her know and she can share it with you. You can stick it up in your office or in your newborn nursery or wherever. I thought that was like a very quick and easy little reference to have. Thank you all for sticking around for several minutes after 1 o'clock. Thank you, Dr. Begue. This was a really interesting and exciting presentation, and I really hope to see lots more answers down the line. So everyone have a wonderful day, and we look forward to seeing you in 2 weeks.